We are now joined with Dr. Wade McKenna. Dr. McKenna, thanks so much for coming in today. Really appreciate it.
Thanks for having me.
Absolutely. So,
see what I'm doing right here?
Yeah.
Whenever Rhonda Patrick goes on Joe Rogan, he's like, all right, everybody get your pen and paper out. You're going to be taking some notes. I'm just like, all right.
My favorite Joe Rogan comment about Rhonda Patrick, he says he never feels more like he's absolutely just a caveman than after he talks to her. Right?
She's got a lot of knowledge.
That's awesome.
She's got a lot of knowledge, but so do you. So,
yes, you do.
I already went through a couple of small things in the last half hour. You played football at Oklahoma State. You've been an orthopedic surgeon for several years, but that's not really what you're here to talk about today.
Well, the cool part is I actually...
Can you hear him?
Uh-oh. We good?
We got a little mic problem. We're going to get something fixed here real quick.
All right.
There we go.
The cool part for me
Thanks, Pat.
Is kind of been allowed to reinvent myself as a traditional surgeon when the science kind of caught up to what we do, and figure out that a lot of what we would think of as traditional medical approaches were less than optimal from a patient standpoint. So I actually did a fellowship in trauma and post-traumatic reconstruction after an orthopedic surgery residency and after a general surgery internship. So during a general surgery internship, when I thought I was going to do transplant surgery, because that was the coolest guys at the hospital at the time.
Where'd you train at?
Here in Dallas, Fort Worth, multiple hospitals, but DFW Medical Center is where I ended up doing my orthopedic residency. I did my fellowship in trauma at Tampa General with Roy Sanders, a 2,000-bed hospital where there was 2 trauma fellows that kind of ran the program. We had 10 residents and 4 helicopters and no sleep.
Which we'll have a whole new episode on what lack of sleep will do to your stem cells. But,
yeah, well, lack of sleep and not healthiest not like lack of sleep induced by fasting where you feel like Superman. Lack of sleep induced of falling asleep in the lounge chair, waiting for the nurse to tap you on the shoulder to say it's time to go from zero to hero.
Yeah.
So, but during the trauma fellowship, we became very adept because we got stuck with a lot of the fractures that other people had treated that didn't heal. And so the post-traumatic part of that is acutely we were stabilizing multiple extremity injuries, but we also had to get those people over the multiple extremity injuries, and we would get referred a lot of the trauma patients, the gentleman trauma is what we called it, which comes to visit you in clinic, doesn't come to you in the middle of the night by helicopter.
The gentleman trauma that walks in your clinic, he's like, I've got this knife stuck right here.
Well, hey, I've had 5 surgeries on my femur fracture and I still can't walk and there's still no bone and it still hasn't healed. And we had to find a way to not only try to trick the body into healing something that already showed it didn't want to heal, but in the least invasive way possible, kind of turn the table to kind of help the patients generate new bone. The best way to do that early on was bone marrow aspirate concentrate. The very best and first uses of bone marrow aspirate concentrate in traditional surgery was in the treatment of non-unions. When someone has a fracture that doesn't heal, there's delayed union, which just means it takes forever. But there's non-union, which just means it doesn't heal. There's no bone. And if you have a leg that doesn't have a healed fracture, you can't walk. You can't put weight on it. You have an upper extremity with an unhealed fracture, you pretty much flail, right? You have a non-functional extremity. Bone marrow aspirate concentrate in the treatment protocol of this allowed us to be much less invasive. Instead of just, it doesn't make a lot of sense to just take out all the other plates, unstrip the blood supply to a muscle, replate a fracture, further destroying the blood supply to the fracture that already didn't have enough blood supply to heal.
So let's go ahead and revisit that really quick, because as a orthopedic surgeon, that's interesting to hear somebody, because that's a knee-jerk reaction. Oh, that last surgery didn't work, let me operate again.
That's exactly right.
So say one more time what reoperating does.
Well, here's the problem with reoperating. If you didn't heal the first time, it's because of the formation of scar tissue, not healed tissue. So the healing gets stopped, the fibrotic tissue begins, scar tissue hurts, scar tissue doesn't have much blood supply, and scar tissue isn't very functional. It's fibrotic. It can take up some space, but for the most part, the interface between the healthy tissue and scar tissue continues to be painful forever, every time you move something. So if you have a big fibrotic knot of scar within a tendon and you have some healthy tissue that connects to it, the mismatch in pliability, that mismatch of, you would never use metals that have different hardness when you're putting together an engine, right? Because the soft metal and the hard metal cause fretting and corrosion and significant problems and metal mismatch. Soft tissue mismatch is just as big a problem. We create scar tissue in people that hurts, generates pain, generates an inflammatory response. So a chronic inflammatory response from cytokines that without decent blood supply to a scar tissue, your body can't get rid of. So you end up with long-term and continued muscle death. And a lot of our surgery approaches, and a lot of surgery where you would just strip off the blood supply to the bone that it needs to help it heal, don't work very well because we're not focused on how the body needs to be able to heal this fracture. We're focused on making an x-ray look pretty. And
ooh, did you hear that?
I did. Just to make it look nice.
So, I mean, I think it's fascinating because essentially I've done the same thing in my practice where I've kind of moved from traditional gastroenterology. You've become almost a functional orthopedist.
Yeah, I mean, I would like to think that that I just come to the table with some of the extra tools that I need to kind of set the table for the patient to help them heal, right? The body has a unique ability to overcome a lot of things, and our body actually wants to heal. A lot of times I'm just trying to help people get out of their own way. The same way that gastroenterology, diet, you're trying to help people get out of their own way from being in bad health, right? Mm-hmm. With orthopedics, I have to help the body. The body knows the triggers and the mechanisms and has the intact growth factors to help your body heal. As we get a little older, as we have chronic injury, UV light, radiation, cigarettes, coffee, alcohol, late nights, cortisol, stress, we impair our body's ability to respond appropriately to injuries. What the stem cell does for you is that's the cell that helps you respond to injury. The problem is, as you get a little older, you have less of them, and they don't do as much as they used to do.
I want to get to that in a second. I want to hear the history. I want to hear your path, because you ended with, during residency, we started to do bone marrow concentrate, bone marrow aspirate concentrate.
For non-union fractures.
For non-union fractures. So you were getting the worst people, so you guys were willing to try some things that other people weren't.
Well, we had the opportunity because these people had no other options, right? So the best part about doing a trauma fellowship is we were their last hope. We were the island of misfit toys, so to speak, right?
Island of misfit toys.
So we used to, you know, especially around Christmas time when that movie comes out with Kris Kringle, we would literally collect the injured patients from all over South Florida, North Florida, Alabama, Georgia. We were the only level 1 trauma center on the west coast of Florida. And so when people would fail multiple surgeries, they'd walk into the resident clinic and you had to come up with a way to solve their problem. And a lot of times it was as easy as finding a way to put more stress on the fracture. You know, they would have some plate that was plated in distraction. So a lot of times it was just taking some screws out. Sometimes it was loosening up a frame that was holding the fracture apart and didn't let the fracture heal. We would compress the frame so that the piezoelectric effect, you know, fractures need stress to generate bone. So stress across bone generates an electronegative charge, calcium and phosphorus are positively charged. The biomechanics of basic physiology, which unfortunately as surgeons, I don't know when we're supposed to forget that, but apparently we do. It's trained out of us. Is what I always tell the residents when they're with us: is don't let basic science and physiology be trained out of you into a surgical approach. But when you create an electronegative charge from a compression against a fracture, calcium goes in, and so you can get some healing. But without blood supply, there's a rule, and I'm an osteopathic physician, so I went to DO medical school. Because our team doctor in Oklahoma State was DO, and getting manipulated felt good, and I wanted to know how to do that, and I didn't even know there was a difference. I knew I wanted to be an orthopedic surgeon. I said, can I be an orthopedic surgeon if I was DO? And he said, absolutely. So I said, okay, I'll do that. That's about how I made that decision. Oklahoma State had a DO medical school. OU's was MD. The last thing in the world I wanted was a red diploma.
Oklahoma State fans are pretty loyal.
So I got accepted at Oklahoma State and OU. That was an easy decision. I didn't even know what a DO was, but one of the DOs at the time gave me a book called The Difference a DO Makes. And he was trying to teach me about the school I just decided to go to. And they said that when it comes to healing, that the rule of the artery is supreme.
The rule of the artery is supreme.
So the rule of the artery is supreme, but lymphatics have veto power, right?
I've never heard this.
So that was it's the foundation of AT Still creation. So osteopathic medicine was created by an MD, right? AT Still was an MD. He started the first DO medical school in Kansas, but he did it because he was unhappy with traditional medical approaches. Mobilization of the joint, instead of letting it get all swollen up, seemed to make the patients function a little bit better, right? And he actually cured the plague by creating what's called a lymphatic pump. People would breathe out all the way, he would push down on their chest, and then he would let up, and it would open up the alveoli, and he could get people over dramatic pulmonary effusions by creating this thing called a lymphatic pump, and it would get the chylomicrons out of the lung tissue. Well, with what we're doing, it literally goes back to the foundations of what created a lot of modern medical science, is that without blood supply, there's no healing, right? And that's true for orthopedic fractures. It's true for muscles, tendon injuries. When we first started doing bone marrow, go back to that point on the trauma surgeon, we weren't real sure that if we put bone marrow into a tendon that it wouldn't make bone. I mean, that was our fear. We thought when we took bone marrow aspirate concentrate, we were real careful to make sure we kept it in the osseous part of the fracture.
Had this been done on animals yet, or were you guys?
Oh yeah. As a matter of fact, there's some really good studies published on bone marrow going back to the mid '90s. There was actually a really great study, but here's how little they knew about what we were doing. In Israel, 20 years ago, there was a study on complex proximal tibia fractures. Which is a disaster. If you have a tibial plateau, the base of your knee, if it's a complex fracture in more than one part, it's called a Schatzker 6, right? So Schatzker's fracture. So if you have a Schatzker 6, we used to call it FUBAR, right? So that was our classification. So we with the Schatzker 6, what they did in Israel is they treated half of them with bone marrow aspirate concentrate, and half of them with just plating and without bone marrow aspirate concentrate. But interestingly, because it was so early, they added PRP to the bone marrow aspirate concentrate, thinking that it made it work better, and really all they did is dilute it down. So PRP, the machine that I helped develop, the arteriocyte machine.
Hold on one second. Define what PRP is.
Okay, so the machine that we work with, the machine that I've been working with for quite a while and have actually helped, hopefully, without, not taking real credit for anything, but knowing that I've been a significant part of the innovation of the development of their kit, right? I actually patented the bone marrow aspirate catheter. The catheter that comes in that kit is my design. PRP is when you take whole blood and spin it down in the machine to concentrate the growth factors and get rid of some of the white cells. And so you create what's called platelet-rich plasma, right? And platelet-rich plasma is generated from the centrifugation of whole blood into the growth factors and platelets that are needed to help get rid of inflammatory change. A lot of times getting rid of the inflammatory change is the way to start the healing cycle. Inflammation gets in the way. You got to put out the fire before you can grow new grass, right? And so with inflammatory change, if you turn the inflammation off, ligamentous tissue, tendons heal faster. With bone marrow aspirate concentrate, what wasn't really understood as well in the 90s, early 2000s, and it is now, hopefully, is that bone marrow is still 97% whole blood, right? So when we spin down bone marrow, you're getting platelet-rich plasma.
So you were actually doing PRP.
Yeah, but you're doing PRP with stem cells.
Yeah.
So bone marrow aspirate concentrate has the stem cells needed to help you heal. And we know that those stem cells, because when I don't know how old you are, but while I was in school, there wasn't such a thing as a mesenchymal stem cell. Okay, a mesenchymal stem cell was named the mesenchymal stem cell in 1995 by a doctor named Arnie Kaplan at Case Western. And Arnie Kaplan named a cell that previously in medicine, what we do is we name cells based on their characteristics, right? So before it was a mesenchymal stem cell, it was an aplastic, undifferentiated, pluripotential adherent cell.
Yeah, I liked it way better back in that day.
Yeah.
I think they got way too uppity by calling it mesenchymal stem cell. I'm old school, baby.
Well, and not only that, but when people use the term mesenchymal stem cell, most of the time they don't even know what they're talking about, right? So there's a CD marker, a surface cell marker. There's 600 different types of these cells based on their surface marker. So when we talk about mesenchymal stem cells, people think there's like one kind. No, there's some of them that we don't really need to help you heal. There's some of them that we need crucially to help you heal. And we know the difference between these based on their CD marker. So we've actually quantitated what cells we want, what cells we don't want, and found a way to concentrate the cells we want when we do these spins. So with bone marrow, you're getting platelet-rich plasma, but you're getting the best platelet-rich plasma because you're spinning it from the most immature blood. When you spin down whole blood, you're getting PRP, but you're getting no stem cells.
All right, so let's clarify, because
it's a definition of terms.
It's
right?
beautiful and it's brilliant, but what you're saying is that saying just stem cells doesn't mean just stem cells.
No.
Stem cells, when we have these mesenchymal stem cells, which is the earliest of the stem cell, correct?
Right.
Then you guys have markers where you can determine the type of stem cell. Which ones do you need?
What ones preferentially help you grow cartilage? What ones preferentially help you grow tendon? What ones preferentially grow fat? Right. So fat stem cells. If you make fat graft or a stem cell graft from fat, those cells grow fat really well.
Yeah.
But you know what they don't grow really well is cartilage, because there's a peptide called SOX9 that's not secreted by the fat stem cell, right? So when we quantitate stem cells, I'm not interested in what those cells could become. Let me just say right now, because this is my pet peeve. If you go to a stem cell lecture and the first slide they show is this one cell can become these 5 types of cells, and the differentiation and the ability of these cells to become these 5 is what makes it so magic. That's completely wrong, right? That's true in the lab. That's not how it works in the body. What happens in the body is your body sees an injury. It secretes cells, starting with the hemopoietic stem cell, which is the CD34, right? So CD34.
All right, hold on 1 second. I've been messaged where it says, okay, I'm getting a little stressed out. I feel like I'm producing the wrong stem cells because I'm putting on weight. How do I change my stem cells to get rid of the adipose tissue?
Yeah.
And then somebody else just sent there and just go, I got lost at CD something or other.
Yeah. So CD3. So you were way more scientific than I thought I would be as an orthopedist. I thought I'd come in, bone bent, me make straight, right?
So when I was a resident, or actually when I was in medical school, the running joke at the time, orthopedics was the hardest residency to get into.
Yeah, but you had to become stupid right away.
And then by the time we were residents, the attendings would just be like, how do we take the smartest guys and make them the dumbest people?
Yeah. We need to unlearn. That's what I talk about when I mean it when I say don't unlearn medicine, right? You get the orthopedic resident. It was the hardest residency to get to, but you were expected to never even look at an EKG again, right? If you walked into a surgery patient and you're like looking at their head or their EKG, the attendings would walk in and go, "What the hell are you doing?"
No, I think the person to actually talk about this is Eric, who you put those people to sleep, where you have a surgeon going, "Can I cut?" And you're like, "No, he's dying."
Yeah.
Right. Well, interestingly, Eric used to put my patients to sleep.
So you would sit there and just be like, Dr. McKenna, are the CD6 and CD7 mesenchymal cells ready?
Well, I remember there was a joke that was, how do you find the orthopedist or the radiologist? And they're going the opposite direction of the code blue. So.
That's exactly right. They're running away from the scene, right?
Yeah.
Well, we used to say, if you have a dollar and you want to hide it from a surgeon or from any kind of physician, there's different places you have to put it.
Right.
If you want to hide it from a radiologist, you tape it to a patient. if you want to hide it from an orthopedic surgeon, you put it in a book, right? So if you want to hide it from a plastic surgeon, well, you can't hide a dollar from a plastic surgeon.
You were going down a rabbit hole there where we were talking.
The CD34, what we were talking about is the initiation of healing, right? So with the CD34, it secretes a peptide called PGE2. PGE2 is one of those keys in starting new vessel growth. Well, the way to grow hair, the way to have ED go away, the way to have stress urinary incontinence go away, the way to have your wrinkles go away, the way to have your fracture heal, the way to have your tendon remodel.
No, you had me at wrinkles, ED, and hair.
Okay,
Yeah.
so we start out, I'm treating non-union fractures, right? Well, we figure out pretty quick that if you put bone marrow aspirate concentrate, it wasn't, and there's a great study published. It was a limb salvage patient in Japan where 15 surgeries, big proximal defect at the proximal tibia, and the general surgeon was livid at the orthopedic surgeons want to put bone marrow aspirate concentrate in the fracture because he was proving that there was no vascularity to the leg. So to backdoor the orthopedic surgeon, this was published as a case report, the vascular surgeon does this arteriogram of the lower extremity, and it shows that there's literally no collateral flow around this fracture site. And this kid basically has a limb salvage frame on his leg with this big proximal defect, 2 years out, multiple fasciotomies, non-usable leg, a MES score really high, needs amputation. The orthopedic surgeon has seen all this stuff on bone marrow aspirate concentrate, wants to inject bone marrow before he takes his frame off. Eventually, as a surgeon, you become kind of emotionally connected to your work, right? The guy does not want to cut this leg off. The vascular surgeon's trying to prove it needs to come off. He does an arteriogram. The family still don't want it cut off, so they have bone marrow injected in the fracture site. At 8 weeks, they redo the arteriogram because the orthopedic surgeon, the arteriogram wasn't ordered by him, but you're starting to see new bone. The kid's having less pain. He's putting weight on the leg. You're getting new bone formation. But they have this arteriogram sitting out there that shows no blood flow. So they redo the arteriogram, and there's all this collateral circulation around the fracture.
All right, so basically for everybody listening, arteriogram is a study where it actually shows the arteries.
Yeah, you put dye in a vessel, and it shows up on an x-ray.
And there was no blood flow going below where the fracture was.
There's no dye. The dye stops, and there's this little bitty pattern, and there's a little trickle of dye
and
down the leg.
And you guys injected something into the bone, not into the arteries.
Not into the artery, into the periosteal sleeve, the covering of the bone where there was no bone, where there was this big bony defect. They put bone marrow aspirate concentrate in there. The way the bone marrow aspirate concentrate worked, it didn't become bone, which is what we thought. What it does is it secretes the peptides and proteins necessary to bring new blood flow, which allowed the bone to heal. So now there's this arteriogram sitting out there that shows no collateral flow.
Say that saying again, that blood flow.
The rule of the artery is supreme.
The rule of the artery is supreme.
A.T. Still, I'll give him a credit for that, from the 1800s. Rule of the artery is supreme. Lymphatics have veto power. And that's a Dr. Graham from Oklahoma State's manipulation class kind of add on there, that if everything's so swollen and blood flow can't get to it, it can't heal.
Yeah. So you guys injected this. This is the first time you saw that bone marrow aspirate, because this is going to be a great segue when we go to the next half hour where we really do jump into the stem cells. Right. We've got we'll try and keep it at a level that we can help people, because I'm getting a lot of things.
I'll go back to the bone bent me make straight. I'm way better at that.
Like I'm being asked questions like, does it help with back? Can you?
Yes.
Does it help with bone on bone? And so we're going to get to that next half hour.
Yeah.
But
and great papers published, right? Everyone that says, oh, there's no literature published. Again, there's been 3,500 papers published with my little catheter and the kit we designed for bone marrow aspirate. 3,500 papers published. There's never been an untoward report. There's never been a tumor. There's never been that you can't reject your own bone marrow.
So this is the bone marrow aspirate injections that you guys are doing. This is the very beginning of stem cell research.
It's the only cell in the U.S. you're allowed to call a stem cell.
Wow.
You cannot.
So you guys literally were the first people playing around with stem cells.
The trauma surgeon department pulling bone marrow. Yeah, not knowing what we were doing. We were using bone marrow aspirate concentrate for the fatty component of marrow that seemed to help fractures heal faster, which is where microfracture surgery of the knee, all this comes in my mind from, we'd do a knee scope, there's an uncovered cartilage area, we poke a couple holes in the bone to let some bone marrow leak into the knee, thinking that helped the cartilage lesion heal. It's called a microfracture. Now, it doesn't work very well. It creates a cartilaginous cap. It's not good cartilage, but it does heal something. But my thought was, when I created this catheter, if a couple drops of bone marrow makes a difference, what would 60 cc's concentrated down to 4 or 5 do? That was where we started with this, to inject into cartilage injuries.
That's where this whole
the beginning
thing began.
of it. That's the beginning for me. Yeah.
Do you think that it's bone marrow and the stem cells that come from bone marrow are really adapt to this type of healing simply because that's where we release our red blood cells from.
It's how your body does it.
Yeah.
Okay, so this is how your body heals already, right?
Right.
We're not inventing a new way to make something heal. This is how the body heals. This is where those, this is how God does it, right? He sends the cell there, it secretes this protein, a vessel grows, you get new blood supply, tendon grows, right? This is how it works already. It's just as we get older, or if you get lymphedema, swelling, the lymphatic flow where I talked about has veto power is a big swollen leg. If you have a big swollen foot, good blood flow can't get to it, right? So it's all about mobilizing an ankle fracture and all this stuff so that blood flow can get to it, because if it's real swollen, you can't put any extra water in a full glass, right? So new water can't get to it. That old contaminated dead water sits there. You have to pour the glass out a little bit to put some new healthy water back in. That's how blood flow works.
Which is why lymphedema and lipedema is so dangerous.
Yeah, and it has absolute control over blood flow to the injured tissue.
Before we dive deep into stem cells, does PRP work? I have a lot of friends that do it.
Yeah, so here's the deal. So PRP is like bone marrow light.
Bone marrow light.
Okay.
Yeah. So PRP is bone marrow with no stem cells. It's a good growth component. It's great at, it's a one-time shot, right? So when you put PRP in something, you're getting a one-time shot of growth factors that limits and stops the inflammatory response from cytokines. You're not going to grow tissue. There's no stem cells. You're not getting a stem cell injection, which is one of the things that pushes me over the edge. Is someone went, I went and got stem cells from my blood. No, you didn't. You got an injection, but it wasn't stem cells. It's PRP, platelet-rich plasma. Now, PRP is also in bone marrow, right? But there are stem cells in bone marrow. So when you say PRP, if you got it from your whole blood, it's just PRP. If you got bone marrow aspirate concentrate, it's all the best components of PRP and stem cells. So that study I was telling you about. So here's how little. So even though they published this great study showing that bone marrow aspirate concentrate helped the complex fractures heal 50% faster, and all of them healed. The ones that didn't have bone marrow, not all of them healed, and they took twice as long to heal. That was published 20 years ago, right? Wow. With bone marrow aspirate concentrate, but they knew so little about bone marrow aspirate concentrate that they spun down whole blood too in the same machine to try to give it more volume, because we thought the PRP might help the bone marrow work better. When in actuality, you're already getting PRP when you spin down bone marrow. So all we were doing was literally in that study in Israel, they were just diluting it.
I was just laughing. This is similar when you say, no, you didn't get stem cell, you got blood. This is when you and I were talking about fasting, and I've had some friends that have maybe overdone it on Adderall a little bit, and they're like, yeah, I've gone 3 days without eating. and Eric's like, that doesn't count. It's cortisol and everything.
Yeah.
And,
That does not
and he
count.
basically made the analogy, hey, it saved some money. I was in jail all weekend. Didn't spend anything.
There's a great, when you guys talked about intermittent fasting, there's a great study published in Cell Metabolism last year that showed that they're correlating it to longevity in mice. And the mice that had the longest food-free intervals actually increased their lifespan.
Well, as you can see, we started firing it up, getting a lot of brain energy going on that last segment. I started getting hot, and I'm wearing my Tequila 512 shirt.
Nicely
which
done.
I believe the two people sitting in front of me happen to have some ownership in it.
Yeah.
And big fans of the product, too.
Yeah.
Yeah. If you're going to enjoy some tequila, you might as well have some Tequila 512.
Yeah, so I'm going to fire a question, but I'm also going to take a little CBD here to regenerate my anandamide and 2-AG.
Nice.
Because I think I spent some there with the trying to keep up with Dr. McKenna. All right.
Which you would have believed that, right?
Yeah.
I mean, it bothers me when someone says stem cell expert. I always look to see who's behind me. But literally, we've done over 10,000 cases in the U.S. now. So
let me throw one out for you. We got a message from Victoria that says, "Can you fix bone-on-bone degenerative discs?"
So here's the short answer, and there's you know me enough already by now to know that's probably not possible. In a good prospective randomized study that started with just PRP, because again, bone marrow aspirate concentrate. The only reason PRP exists as a product is because we couldn't get approval for bone marrow, so we were spinning down horse blood. The equine market, you could sell PRP into. People will pay more to have their horse injected than they will their kid. And the horse has 4 extremities. And so we were spinning down whole blood, created PRP while we were waiting on the FDA to approve bone marrow. Whole blood is exempt, and bone marrow wasn't. And so to get the validations on bone marrow, a lot of PRP was created. There you go. So the short answer is interdiscal injections there's several great papers already published. And the most recent one, at 2 years, 92% of the patients that had interdiscal injections on degenerative disc disease, and I would take it even a step farther. In our clinical practice, we've done over 300 discs now. In that, if you have an annular tear, I mean a tear in the covering of the disc, that is a primary pain generator. It's a bright spot on the MRI called a high-Z lesion or high intensity signal. A lot of radiologists don't fail to mention that, I guess. But if there's an annular tear, a high intensity signal within the disc, that alone is a dramatic pain generator. It can even cause the exact same symptoms as a herniated disc would as far as lower extremity pain and weakness, because the nerve crosses that annular tear. The annular tear generates substance P, generates the cytokines, generates the exact same pain response. So there's 2 times of radicular pain coming from the back, leg and hip pain, radicular. So that's the old folks called sciatica. If it can be pressure caused by a big herniated disc, neuroforaminal stenosis, meaning the canal gets too tight, the facets in your back get hypertrophic, get extra large as they wear out. So you can have pressure, stenotic pressure on a nerve where it feels like it's just being crushed. That causes leg and hip pain and back pain. Or you can have a chemical radiculopathy created by a tear in the disc, and it feels the same. Patient can't tell the difference. But
That's
one of
because
them,
almost everybody always says my bulging disc.
Yeah,
right. It could be.
Yeah. But bulging discs aren't the problem, because here's what we know. Here's what's already published. If I do MRIs on a lot of people that have no back and leg pain, then a lot of them have bulging discs. So how does it happen? How come some people's bulging discs hurt and some people's bulging discs don't, right? Not only that, if you have a bulging disc, the non-operative follow-up at 2 years is the same as the operative follow-up. If you don't have weakness, if you have pain that you can tolerate and you don't have weakness in the lower extremity, at 2 years, you're doing the same as the people that had a discectomy if you don't have surgery.
What?
Right?
Wow.
Yeah,
Wait a minute.
That's published for a long time.
So we're not.
So if you
helping.
extrude a free fragment, that free fragment will absorb. Your body is really adept at getting rid of items extruded into the canal, and it will absolutely absorb and get rid of a free fragment, as long as that free fragment isn't putting so much pressure on the nerve that it decreases the blood supply from the pressure, it causes weakness in the lower extremity from the pressure, the nerve stops working, you have leg pain, you get a little foot drop, you get a little weakness, you need to have surgery. You don't have weakness and you just have pain. What's published now is if we inject that disc, the annular tear that doesn't go away on its own will heal. And most of the time, 92% in that study, if the annular tear heals, the back and leg pain go away.
92%.
92% of the patients that had an injection didn't go on to a primary fusion.
Wow.
Now,
here's the other side of that. The patients that had a fusion, at 5 years, 30% of them had 2 surgeries. So if you have a fusion at one level, 30% of the time within the next 5 years, you're at risk of having a second surgery, either a fusion at the level above or below, or hardware removal or revision, or you get extra bone from the fusion and they have to reopen up the nerve roots, they have to do a nerve foraminotomy. Every time you do surgery, the muscles of the back die a little. So the paravertebral muscles, the muscle mass. So when you look at someone bend forward, that little, it looks like a dinosaur, right? That little thing, the ridge that sticks up in the middle of your back.
Sure.
That's called the spinous process. The muscles that lay on each side of the spinous process have to be moved out of the way for you to do a back surgery. We used to make fun of the spine surgeons when I was a fellow in trauma because they only have one incision, right? It's midline and low back, right? We had to learn all these other incisions, and spine surgeons learn one. But what they don't learn, that trauma surgeons learn, is we make an incision that is designed to not limit the structure, function, blood supply, or nerve to the muscle we're moving. In the spine, the multifidi, that small muscle on each side of that ridge, the nerve and vessel come from the midline of the back, but we're moving that away. And so when you do an MRI of someone's back that's had back surgery, Initially, the muscles on each side of that look like filet mignon. That's tenderloin, right? That's the backstrap.
Hey,
right?
we're fasting.
For hunters.
We're not talking tenderloin right now, okay?
Yeah. Well,
I'm real hungry.
So when you move that muscle out of the way and you go back and you do an MRI of that back that had surgery, and now they're 5 years out and they're having pain again. And the neurosurgeon looks at the films and goes, wow, the disc looks great. The nerve root's wide open. You just want pain meds. There's no reason for you to be here. Your back's fine. Well, if you look at the MRI, though it used to look like tenderloin, now looks like like strip steak or worse. Just we call it white muscle syndrome. The whole thing just looks like fatty infiltration.
Oh, like Arby's.
Like prime, like more like prime rib, right? So there's a little bit of muscle mixed in there.
There's not a diagnosis Arby's bag.
Yeah, you are fasting for way too long when you're talking about Arby's. Roy Rogers from my generation.
Hey,
Right?
let me ask you a follow-up question to that. She was asking how many injections did that take to achieve the 92%?
Most of the time it's one.
One injection.
One
So
treatment.
one injection for 92%.
And what we do is we want to be more specific, right? So my problem with stem cell science as a whole is a lot of times patients get in the mix where they're never really diagnosed. And I'm a firm believer that you can't treat something if you didn't diagnose it. If I don't know what I'm treating, my chances of making it go away are pretty slim. And unfortunately, a lot of stem cell injectors out there don't make the effort to actually diagnose a problem, but they're willing to inject anything. Well, that's very nonspecific treatment, and it kind of puts your results at risk if you don't know what you're treating, because you don't know what you can heal and what you can't heal. What we do when we're doing a disc injection is I want to know that was the pain generator, right? So there's an old test that used to be the standard of care before you had a fusion. Now, because fusions are so rampant in our country, we've gotten away from more specific diagnosis on making sure that the fusion was necessary. And they do it based on MRI criteria. Well, MRI criteria is not very specific, because you can have 3 discs that look really bad on MRI and the patient not have any back pain. Or you can have 3 discs that look really bad on MRI and only one of those discs be causing the patient's primary pain. And you don't know. So what you do, or what they used to do a lot and what not a lot of people do anymore, is to do a discogram. You literally put a needle within the disc of the back while the patient's asleep. You kind of bring them up into twilight a little bit, and you inject dye into the disc to increase interdiscal pressure and see if it leaks. So if the dye has a tear and the dye leaks out, or it has a really disrupted pattern and it causes concordant pain. So there's 3 things to make a discogram positive.
So let me get this straight. When you guys are looking at a bad MRI, you have a patient that hurts.
Right.
They've got bulging discs. They've got this. You go to each disc and see?
So what you do is the ones that look the worst, right? Especially ones that have an annular tear. We'll put that patient asleep. We'll put a needle in at least the.
And this is different than a myelogram.
Oh, absolutely. A myelogram is just putting some dye within the canal.
Okay.
Right? It just looks for pressure. It looks for areas that are tight, right? The discogram is positive if 3 things happen. It needs to cause pain. So if I inject your disc and you get this nice little pattern within the disc like a jelly donut, so the disc is kind of like a big jelly donut, right? The middle part of that is the consistency of like crab. The outer part of it is big fibrotic, thick, ropey type tissue. When you tear the rope, the crab can kind of leak out and put some pressure on it, and your body kind of scars that in. So it doesn't often generate a big free fragment, but it generates a smaller canal. And myelogram will show that. But discogram, you're injecting into the disc. When you put dye in the middle of the jelly donut, if it doesn't have a disrupted pattern, it doesn't leak everywhere, and it doesn't cause pain, that's not a pathologic disc. Even if it looks black on MRI, even if it looks like it's herniated, if I inject dye in it and you have no pain, it's negative, right? A lot of negative discs are fused. That's why not a lot of people.
All right, so
that's what happens when someone doesn't get better.
Okay, so you just covered something so yesterday I had a friend text me. He's like, hey, give me the name of a good back surgeon. My back's hurting. And I'm like, well, I'm like, what is it? Are you looking, is this something that's a chronic thing? You start asking questions like, is this a rehab thing? Is this whatever? And his response was, I've been cut enough. I'd prefer to avoid it. And then you start realizing, oh my gosh, wait a minute. There's a lot of times
you got to get the diagnosis right? Because there's a lot of pain generators in the back. The facet joint can cause pain. The muscle deterioration after surgery causes secondary pain, because that muscle that we kill, that multifidi muscle on each side of that ridge down the middle of your back, as that goes away, that's the primary posterior support of the little facet joints on the side, and it ends up being the primary support for the SI joints, both sides of the back of your hip. So all these people that have fusions or have a laminectomy, a lot of them end up with, about 5 years later, their back's hurting again, their facet joints hurt, and so we inject their facets and do some epidurals.
Now you're talking not stem cell injection.
Not stem cells. Now, this is traditional medicine, right? And then it's down into their SI joints. Now they're getting SI joint injections. All you're doing is kind of chasing the rabbit of deterioration of the muscle mass that was killed at the time of the laminectomy. So what we do with that patient is you take the dead paravertebral muscles, just like we would if you have a big disrupted tendon. In 2013, we published a study where 10 centimeter mass in the middle of Achilles, we didn't reconstruct the Achilles. I injected cells in it. It completely reformed. The most amazing part is we actually published the study 11 weeks later because she had no pain and was playing tennis again after being out of the sport for 10 years. At 32 weeks, she's English. At 32 weeks, she comes back over to this country. We're having dinner, and because she wanted to take me, my girls were big fans, and she agreed to go to dinner. So we go to dinner, and she says, Dr. McKenna, my bump is gone. I'm like, what? She goes, the bump. My mass, it's gone. So I'm crawling around the floor at Brio's in South Lake trying to look at this, much to my daughter's chagrin, right? But she's right. The mass is completely gone. So I said, look, do you mind if we get MRIs of both your tendons while you're in town? I said, no, that'd be lovely. So we get MRI. So we'd already published the paper that at 11 weeks we'd healed this disrupted 10 centimeter mass that had been there for a decade in Achilles.
And this 10 centimeter mass you keep referring to is basically scar tissue.
It's all scarred in tendon. Like it's like the rope comes undone. It's a big frayed out knot, right? Well, that frayed out knot hurts, and it's a mass. And she never had it fixed because no one would ever promise her a result.
And they wouldn't promise it because
you can't promise a result when you're fixing a tendon that doesn't have very good blood supply. The complication of Achilles tendon surgery is what ruined Dan Marino's career, right? So they can't make it heal. Well, we can, but you have to do less, not more. Matter of fact, there's a lot of move in medicine now to go away from operative intervention into Achilles tendons and just go into functional bracing because the results are about the same as far as return to sport and pain relief.
So I might as well ask you this because you always hear this. So there's so many physicians at the hospital that are early 40s trying to get out there, and they go and they join a rec soccer league and they blow their Achilles, and I see them
wounded warriors.
Yeah, and it's a common injury. Do you operate on a torn Achilles?
It depends on how much retraction there is and how acute it is. Sometimes we'll do a very minimally invasive, limited approach to kind of reapproximate the tendons, wrap it in a graft and inject it with cells and get those patients moving. Previously, this was a 6 to 12 month kind of thing. I don't even keep people in a brace longer the first couple of weeks. Matter of fact, in the patient we're talking about, I never braced her, kept her in regular shoe wear. At 32 weeks, when she shows back up with the normal size tendon, we redo the MRI. You can't tell which side's hurt. So what we didn't know,
what was it? One injection, one stem cell injection,
one treatment. And what we didn't know, that wasn't even part of my hypothesis, right? My hypothesis was, I'm going to get rid of the inflammatory tissue. I'm going to help get rid of some of the fibrotic scarring that's painful, and I'm going to help give a better quality of tissue within the tendon so she hurts less. What I didn't know that those cells were capable of doing is completely remodeling the tendon. So that 10 centimeter mass remodeled. When you look at an MRI, they refer to it as heterogenic, meaning lots of signal, disorganized fibers, or homogeneity, which is nice black laminar collagen fibers, right? She had complete homogeneity of the tendon that we had injected. And exactly, so the tendon on her opposite side is 2.4 centimeters around. The tendon on the side we had injected before was 10. Now it's 2.4 centimeters around. I could not have done that surgically, because surgically, if I open it up, I'll try to make it the same size as the other side. But part of the healing is either atrophy or hypertrophy. It kind of scars in and gets a little bigger, so you get a knot. Without surgery, her body was able to remodel that tendon exactly the same size as the other side. So we actually published the follow-up as a letter to the editor of the first journal that published the 11-week follow-up showing it was healed. Because even though when we stopped short, like when it healed, we were like, hey, look at us, right?
All right, so I think this is a good time to geek out again. So you're saying you inject this into this knot.
Under ultrasound, I take the needle, go all the way across the tendon, and kind of inject. Look, I worked as a kid, right? So I worked in the oil field. My parents had a tong service, landscaping. I worked. It wasn't like now in South Lake where they bring in an Insta-yard and lay down all the grass. Right? When I was a kid, if you had a pallet of grass, you had like an acre out of that.
Yeah.
Right? We broke it in little pieces. You sprigged the yard. Right?
Sprigs, yeah.
So that's what we do with the tendon. I'll take that big 10-centimeter mass. I'll take a 3.5-inch needle under ultrasound, go all the way across the mass, and kind of inject as I come back.
And so you're injecting the stem cells as you come back.
Create a pathway through that tissue to kind of sprig the yard with new tissue. The way I think of it is you have all this dead yard. You're trying to bring some more grass back to
like
it.
seeds.
Some creeping substitutes.
So I want to
Exactly
know.
right.
I want a little bit more. You say to create new tissues. So the stem cells go, oh, this is an Achilles. Let's become Achilles.
Yeah. And oh, by the way, there's no blood supply here. And oh, by the way, this is a lot of fibrotic tissue here, and it's under a lot of stress.
That's what I want to know. How does it get rid of the fibrotic tissue? I get that we've got these.
The collagen fibers are all there, right? It's disorganized, doesn't have much blood supply. You're literally repopulating an acellular area with tissue that secretes the peptides and proteins necessary to cause cellular infiltration with new blood supply. Microangiogenesis,
Okay,
the
so
growth
these
of new
cells
vessels.
start growing blood vessels, and then they also send out
The sentinel
cytokines
proteins.
that get rid of the fibroblasts, creating the scar tissue.
Remodeling of fibroblastic tissue.
Wow.
So it's not just that it's growing this new place. It's smart enough to say we need to get rid of this so that we have room. We need to increase blood flow over here. So it's
And
almost,
oh, by the way, this tendon needs to be 2.4 centimeters around. We need to remodel it and shrink it down. And we didn't do that, right? And that's published in a lot of studies. Look, there's a rotator cuff study, and this is what drives me bat crazy.
you can use foul language. on
I'm
this
sorry,
show. It's,
I left out that word. My mom may listen, and so I don't want to use that word because she will be horrified. But what drives me crazy is when people talk about, oh, there's no studies. There is 10-year follow-up on a rotator cuff study. So in 2002 to 2004, a doctor in Paris named Phil Hornigow, because we didn't have the kit approved in the U.S. yet, used our kit with our Arteriocyte to create bone marrow aspirate concentrate and inject into rotator cuff repairs. All of the patients went to surgery for a full thickness rotator cuff repair. 45 with cells, 45 without, right? What's published in every long-term rotator cuff study, and you never hear your orthopedic surgeon tell you this, but orthopedics' dirty little secret, that surgery has a 30% failure rate. So what's published in every long-term rotator cuff study is only about 70% of those patients get better. And Dr. Hornigow was destined in his mind. He thought there's no way that my study is going to look like that because all surgeons think their results are better than they are. In my experience, that means you've done one. And so I hate that, right? In medicine, when you say time after time means two, and in my experience means you've done one. In my series means you've done three. So Dr. Hornigow was
if
like,
you do 4, you're going to publish it.
yeah, if four is a long-term follow-up, randomized
4
prospective.
You go on the lecture series.
Yeah. 4, I'm speaking at the academy. I've done more than all the other guys. So Phil, he was sure his data was going to be better, but in what he did, they did MRI as part of the French healthcare system. So it's all all those patients are, if they don't heal, you're still liable for them. It's all one payer group, right? Socialized medicine. So at 6 months on MRI, the ones that didn't have bone marrow, only 67% were healed. Oh. Same as the U.S., 30% failure rate. And the ones that had bone marrow aspirate concentrate, 100% were healed. So 45 healed at 6 months on MRI. The only difference, bone marrow aspirate concentrate. Now, 67% of the 45 without. Now, in Paris, and we could never do this in the U.S., in the U.S., that means the study is over. The 33% that didn't heal need to be injected, right? Not in Paris. In Paris, they continue the study for 10 more years with multiple MRIs. At 10-year follow-up, only 44% of the patients that didn't have cells are still healed. 87% of the patients that had cells are healed.
Wow, it's twice as much.
Twice as much.
This is amazing. That
was published in the Journal of Shoulder and Elbow in 2014.
2014. This is going on.
Yeah.
And we've got both objective and subjective data and the outcomes.
And functional outcome data.
I was just going to say, and the outcomes and the safety data.
Yeah.
This is exactly like what we were talking about before in the cannabidiol industry, the photobiomodulation.
But you're told that doesn't exist, right? Like there's no reason to, but there's stem cells in the cuff doesn't work. Oh my God. I mean, other than 10-year follow-up, what do you want? I mean, so here's the real issue. Those were all patients that were taken to surgery for full thickness tears. What about the patient with the partial thickness tear that we're operating on? If they don't need a decompression, if they don't have some big spurt pushing around on the cuff, most of our patients we inject under ultrasound and it gets better. They go away.
All right, so I want to take this opportunity to look because I'm getting questions about where. Well, number one that's popped up a couple times. In your clinic, do you guys accept insurance
for the surgery part? Sure, yeah. So I'm a traditional orthopedic surgeon still, right? I mean, I still do 50 surgeries a month and see 400 patients, and I have a PA and nurse practitioner, and so. Matter of fact, I still take Medicare because I still do total knees.
But does insurance pay for the stem cell?
Insurance does not pay for the stem cell injection part of this. And not only that, if it's a non-surgical patient, if it's someone that just wants stem cells injected to the cuff, the insurance doesn't pay any part of that. If I'm doing stem cells at the time of your cuff repair, a lot of times we get the bone marrow as kind of part of the surgery itself.
Okay, so I know that you're an orthopedist, but as we go head to toe as we're closing down this, where can stem cell help when you start looking at a body?
Well, here's the cool part. So I have a business partner that's way smarter than me and way more money and been doing it and made way more money than I'll ever not make. And he followed me and listened to what we were doing for years. His kid plays at Kansas in basketball with a pretty elite program. I've taken care of a lot of athletes that are personal friends of theirs, and I've taken care of his wife and his kids. Brian is if you can, what about hair and face and all these other problems? Because the PRP product that we help create, right, is used for hair growth for 10 years. There's a book actually called The O Shot that's published on injecting the periurethral
Robin
tissue.
Benson's the one that told us about that.
Yeah,
so Charles Reynolds, the guy that uses our kit, the PRP kit from Arteriocyte, and just uses PRP, no stem cells, and it works. But if you put stem cells periurethral, at 2 years the stress urinary incontinence is still gone compared to a bladder sling. Matter of fact, we've injected patients now for stress urinary incontinence that have had 3 bladder slings, still had stress urinary incontinence. You do a periurethral injection, you inject the clitoral tissue, the superior vaginal wall, anorgasmia goes away. Women become sexually mature again as far as their orgasmic response, and the stress urinary incontinence go away. Then cough, laugh, or sneeze, go to a movie. ED was published in 2009. Now we'll get back, but
So basically, anywhere in the body.
Yeah.
Wow.
Anywhere that has a blood supply problem or failure of the tissue.
There's a lot of applications. We'll get to that and the FDA problems next. We're back with the last half hour, and I'm not going to waste a whole lot of time with a whole lot of intros. We are going to start off. Dr. Brown, you had some questions during the break. You were going to ask Wade just the applications and Panama.
Yeah, so basically I was asking you what different places could be, and you said any place where there's blood supply. And then I remember when I was watching the Joe Rogan show, which with your business partner, Neil Riordan, you guys had a clinic in Panama, and then they were talking disease states. So,
right.
I mean, we're not saying anything that's going to step on the FDA. You're not recommending it. But what diseases have they done, especially in Panama?
So Neil has really good, and Neil's a PhD, not a clinical physician, so he doesn't have that patient care responsibility in the States. So, but as a clinical professional, he designed a process that in Panama for the administration of IV cells. And the best use of IV cells, like we talked about before, it's about what they secrete, right? So autoimmune disorders, rheumatoid arthritis, MS, autism. I think Neil published a series recently of like 2,000 or 2,500 MS patients that have no brain and spinal cord lesions that are more than a couple years out. And there's some fairly famous local MS patients that were pretty well disabled in a golf cart and a wheelchair and are running around on the sidelines coaching football again. When
from
Neil,
IV injection,
from IV therapy,
letting these
cells get caught
cells
up in the pulmonary parenchyma, right? I think Neil's protocols are like 120 million cells, 20 million cells per dose. It's 5 injections over a period of several days. He's been incredibly adept at treating autoimmune disorders. Now, there's some of these disorders that you have to continue to treat. I mean, one-time treatment, you'll burn through those cells eventually, and those cells aren't going to give you all new cellular volume, and so you'll have to get some of those have to be retreated, especially with like rheumatoid or some of the more aggressive, like pulmonary fibrosis. He's treated. There's actually Okeanos, a heart hospital in the Bahamas, that's been treating heart failure for a decade.
With this stem cell?
They're using a different cell. So Neil uses cultured cells from the umbilical cord on the Wharton's jelly in Okeanos down in the Bahamas. Currently, what they're doing is they're taking a construct from fat called SVF, digesting the tissue, culturing those cells, and injecting them IV and curing heart failure. Now, heart failure has been cured for a long time. So there's a study.
Heart failure has been cured for a long time.
Yeah, just a side note. I remember going to your clinic about 3 years ago. I just stopped by for a visit, and you were holding in your hand the increase in ejection fraction specifically to CHF.
Yeah. So there's actually a study published called Symbiosis, and it's a rat study out of Harvard 10 years ago, 15 years ago. They took cardiac failure that was induced chemically in mice, connected the vascular system to a non-disease mouse. The heart failure went away. So
Wait. Say that again. They connected the vascular system. Did they sew two mice together?
Yeah.
What?
Yeah. Literally, yeah. It's called symbiosis, right? So
That's a very pleasant way to say we're going to do some Frankenstein mixing here.
Well, here's the problem. Here's what has to happen. The mice that didn't have the disease has to be able to sense the heart failure and still be healthy enough to secrete the cells necessary to treat the heart failure. Right?
It's like that new Samsung where I can charge your phone if you put yours on mine.
That's exactly right.
That's how the movie Human Centipede started.
Yeah, so the diseased mouse wasn't able to secrete the right cells to treat his heart failure.
I just want to say that I had an over-under of how many episodes we would get in until Eric would bring up the movie Human Centipede.
Human Centipede,
It took exactly 6.
Do we meet it? Nice. You should have. We do this again. We'll be talking about zombies and shit later. But that study was published a long time ago. So at the time, didn't even know why the heart failure went away. Now we've actually isolated the peptides and proteins necessary that were secreted to make the heart failure go away. There's a mouse study done on, if you want to talk about just one beneficial effect of stem cells that's way underappreciated, it's the prevention of infection and treatment of infected wounds. There's a study done out of San Francisco where they took mice and iatrogenically created 6 different types of nosocomial pneumonia, what you would get in the hospital.
Right.
They didn't treat the mice with antibiotics. They took bone marrow aspirate concentrate, made it as a slurry, treated it with a spray, pulmonary spray, and cured all the pneumonia in all 6 different types of mice. Then they took the alveolar, they sacrificed the mice, take the alveolar washings, and could not culture out the bacteria on the alveolar washings. There's a peptide called LL37 that is secreted by the cells from bone marrow that is extremely bactericidal and helps modulate T cell function. So stem cells can only do 3 things, right?
Well, look, hold on. I'm going to stop you right there because I have a friend he's a bodybuilder peptide expert. And we got to talking that a lot of in the bodybuilding community, people are using peptides. So the way are we talking different peptides? Can I just take the CHF peptide and fix CHF?
That's the big intellectual property grab right now, right? Everyone trying to patent a peptide. My theory on that is, you want to listen to the orchestra or trombone? Do you want to have a full spectrum or an isolate? Yeah, I'm just telling you, the stem cell, I don't have to tell the cell what peptide to produce. It knows, right? It knows, yeah. So if I concentrate the cells and put them where they go, your body knows what it needs. It's the difference between if you're hungry, going to 7-Eleven or going to Central Market. Where are you going to have the most choices? I think when you start isolating different peptides and proteins to give to people, you're limiting what the body's really capable of or what it may need, because it may need some of the other cofactors in there. So you want it to have central market of choices, not 7-Eleven, right? It's a great analogy. So I think that's crucial.
So you've talked about your experience in making sure that people get the right stem cells, making sure that a diagnosis is important, making certain that people know that you can treat different diseases. What is it that you feel the next generation is? You mentioned exosomes before we started.
So I think the way to differentiate, so that we get rid of some of the guys that think, and God bless the doctors. Look, I know how hard it is to make a living as a physician. I'm not throwing rocks at all, because the doctors are told stuff and they don't know, right? But most of what's being injected out there, called a stem cell, is completely acellular and has no stem cells in it. And for the most part, doesn't have a whole lot of growth factors. The most popular amniotic graft on the market right now has between 50 and 150 picograms of PGE2. PGE2 is that one compound we're talking about that helps drive initial formation of new blood supply. And that company is publicly traded, and it's down from about $12 a share to about $4. So it shouldn't be too hard for everyone to know what I'm talking about, hopefully. But the graft that Dr. Riordan and I designed, we got that graft, an injectable amnion, up to about 800 picograms of PGE2.
Okay, now what did this other company that the stock dropped? What was it? How many picograms did they have?
About anywhere from 50 to 150. So there's not even really good standardization, right? So with different doses, we get somewhere between 50 picograms and 150 picograms. The graft amniotic therapies, the company we had started back in the day, got about 800 picograms of PGE2. The reason for Neil and I's falling out, where we're not in the same clinic anymore, is because a new graft came out. And as the physician, the one that actually has to treat the patient, I'm not using the graft that has my name on it anymore. So the new graft, a company out of Grapevine, has about 3,200 picograms of PGE2.
3,200.
Wow.
You guys had 800.
Yeah. And Mimetics, what did I say that?
Mimetics.
The original, the largest maker graft, has somewhere between 50 and 150.
Hey, let me not to go down this rabbit hole, but I'm impressed by this. You said that the reason why Neil and I are no longer business partners is because of this one thing where basically somebody came out with a superior product. Your name's on the other one.
Yeah. Yeah, and it's unfortunate for me, right? Because financially, it would make sense.
Well, it's gonna affect the friendship that you have. It's gonna affect the business.
Oh yeah.
And it's gonna. I'll say this. Almost all doctors I know do not have that level of humility to go, my name's on this one, but wow, good job, guys.
Yeah.
Let's start treating the people the right way.
You know what? My life is so uncomplicated if you just do the right thing. I literally, I don't always make the best decisions in my personal life. I'm a mess, right? But when it comes to taking care of patients, I've always been laser focused on making sure I do the right thing and try to put what's their best interest first. And they're trusting me. I feel very medieval about that doctor-patient relationship. When a patient's asleep, it's like you're a knight with a sword standing by the bed ready to smote anyone ready to hurt them, right?
Sure.
I mean, you're their only protector. They're trusting you to put themselves in a completely flaccid, asleep state and counting on the fact that you're going to make them better when they wake up. And
they have to wake up though. Remember?
Yeah, but Eric has to take care of it. But that oath we took, still, PhDs don't take that oath, right? They're allowed to just be businessmen. As a physician, you really can't. I mean, that there's a lot of way better business people in medicine than me. But I don't think there's a lot of people that have worked as hard to hone their surgical skills and the decision making as I try to make it patient specific when I take care of it.
Do you feel like that stem cell nomenclature will change more towards the exosomal?
Yeah, so here's what we're trying to do, right?
Okay.
Because I think that it's important to set the good products apart from the bad products.
Right.
I always use an analogy that you would never pay Kobe beef prices for hamburger, but people are, right, in stem cells because you don't know if it's Kobe beef or hamburger. But the way to tell is we need to start talking about what's in it or what's produced by it, which is exosomes. The reason the stem cell works, or the way a stem cell works, is exosomal secretion, growth factors. So we talk about growth factor secretions and quantifying how much growth factors is in this, how much growth factors is secreted by this. That's the difference between bone marrow and PRP, right? PRP is a one-time shot of growth factors. Bone marrow is an injection of cells, one-time shot of growth factors, but those cells continue to produce growth factors for 16 to 20 weeks. Lots of PRP shots if you give a bone marrow injection, not one, because those cells stay metabolically active. With amniotic tissue added to it, so as a tissue graft, now we have day one cells. So if I use your bone marrow has seen UV light, radiation, everything you've ever done. All your stress has had an effect on your quality of your bone marrow. Amniotic tissue hasn't seen any of that. It's day one tissue. Now, it's stupid, but it's really strong. Produces a lot of stuff, but I don't know what to do with it. Your bone marrow is the director of the play. It can be, a movie in a warehouse with 5 guys that everyone dies, or it can be Lawrence of Arabia, 100,000 people in the cast. The larger the cast of characters, the more that's possible. And that's what amnion does. It gives you all the growth. The analogy I use all the time is if you're moving, you want a guy like me stacking the truck, because I'll turn the sofa upside down, I'll put the table on the floor, I'll get everything in one truck. But I want a bunch of 17-year-olds helping me get all the furniture out of the house. But if they stack the truck, you'll make 5 trips, right? Bone marrow stacks the truck. Amnion delivers you a real high concentration of growth factors and exosomes.
You actually lost me there for a second. So are you saying that the amniotic origin of these cells is the superior one, or the bone
In
marrow?
growth factor number only, right? So when it comes down to just pure amount of exosomes right at the beginning, your bone marrow is kind of limited sometimes. If you're 70, right? If you had radiation therapy, you smoked ever, if you drink a lot, so your cells...
I like how you looked at Eric when you did that.
Yeah. Well, he did get me involved in 512 like 10 years ago, so he may be responsible for my Lyme affinity. I tell people all the time I don't drink. I'm just addicted to Lyme. So, but all that has an effect, right? Age has an effect. So you do not have as many cells as you were born with.
So do you guys mix the two? Is what I'm getting at.
Well, now that would be the FDA would hate the wording on that. I will inject the two in the same location. Right? So I'll use your bone marrow to get all the initiation, the healing started, because it's the smart cell. And it's the stem cell, right? If we're doing a stem cell injection, it's bone marrow. If I'm using amnion, I don't talk about it as a stem cell injection. It's growth factors. It's an amniotic tissue graft, because that's the way the FDA says it has to be worded. I'm injecting an amniotic tissue graft into an injury. Now, we've used amniotic tissue since 1910. So the year Marconi invented the radio was the year the first amniotic tissue was paper published in medicine for burns and corneas. But it was dead, right? But it helped burns heal and it helped corneas heal. Now, we don't have to kill the amnion. We can sterilize it. This is where genetic testing is coming so cool, because now we do a genetic swab of the mom, the baby, the membrane. We know that that graft doesn't have the gene for cancer someday, let alone any disease now, right? So genetic testing made it where I can take this graft, not have to irradiate it, not have to kill it. I can freeze it down to minus 80. I can make sure it's sterile. We can wait for the cultures to get back. The way to test contamination of graft is endotoxins, right? So sterile water has 0.050 endotoxins, or 0.054. That's qualified as sterile. Our graft has 0.050, so it's more sterile than sterile water. But it's live, healthy tissue that your body cannot have an allergic reaction to. Amnion is completely immune privileged. It's what protects mommy and baby from each other, right? And it's really good at that. But it also secretes all the growth factors necessary to help you become a baby. Now, we don't want baby. I don't need anything fetal. I need maternal. So the amniotic membrane, the placenta, is maternal tissue. Everything that comes out of mommy after the baby, those are the cells I need to help you heal. Because I don't want you to turn into, there's some studies out there where they took fetal stem cells, injected them in the back, and guys grew teeth out of it, right? A teratoma. Well, you're never going to get tumor formation from.
So Mel Gibson wasn't
tissue.
that far off about growing a mouth out of the side of your face.
Hey, man. Well, Mel Gibson's a big fan, right? So Mel went on Joe Rogan and told him I cured his back. So I'm not speaking out of turn to say that when he went on Rogan and said, we cured his back in South Lake, that, we must have done something pretty. He had he had significant issues.
All right, so now this is a perfect time to sit there and get into why in the world are we not doing this everywhere?
FDA has been an issue, right?
Well, yeah, and it's the FDA is a huge issue because of the way the drug company FDA paradigm works. We're the only country where you spend $5 million to get a job that makes $60,000 a year. Mm-hmm. Where does that $5 million come from, right? in 2008, I don't know what happened in 2008, but in 2008, something politically happened where the FDA was less than 20% of the size it is today. And it didn't really govern tissue graft. Fat, taking stromal vascular fraction, digesting it, culturing it, wasn't a big deal before then. Those were, we could get the stem cells, and they're not the best stem cell in the world, and bone marrow wasn't even really regulated. So it wasn't the best stem cell in the world, but it was readily available. We knew how to get it, and digesting it wasn't against the law. And now digestion of the tissue is qualified as more than minimally manipulative to the cell and is against the law. And we can't culture it. We can't expand the fat as a subset by itself isn't a great graft unless you grow it.
Sure.
If you get a lot more cells, it can be viable, but it's not good just with the, I mean, it doesn't do much. It's pretty inert.
So where's the future going to go with the FDA and the recognition of the
we have
advances?
to politically change the environment, right? We have to make it where every congressman and senator isn't put in place by a drug company.
Is that what's holding you back? I mean, because I think what's holding, when we had, who's our guest that talked about policy?
Oh, Joy?
Joy. When we had Joy on, it's a lot of misinformation. Basically, it's old archaic laws that carried over that still listed hemp as this Schedule 1. In this case, is it misinformation?
Man, I would love to think that, but I will tell you that when 90% of Google's ad revenue comes from Viagra and Cialis and statins and Humira that destroys your immune system. If we publish a paper and you don't know where to put the comma, you're not finding it. And it's not artificial moving us down the ladder. I mean, I have to feel like that, when a drug company puts something out, it's way at the top of the food chain, even if you do a stem cell product. Same way with hemp and CBD. If they make it a drug, it's gonna, it'll get through it really quick. If it's homeopathic or you can grow it in your backyard, all of a sudden it's a class 1 drug. The U.S. government used to pay people to grow hemp. I mean, there's an old commercial, rope wins wars. The federal government during the World War was paying farmers to stop growing corn and soy and grow hemp because we needed ropes.
Right.
Ropes win wars, right? And, somehow with Prohibition, we got tied into that. And then when they repealed it, it didn't get repealed.
Right.
But it just got bundled in with alcohol during Prohibition. That's what happened. But the legalities of it, the regulatory part of it, is because that's about when drug companies started to get popular. Medical school was started by the Rothschilds, who, oh, by the way, owned the first drug company. So they had to teach guys how to write their drug. So, I mean, it's not a conspiracy, but...
Well, I mean, I'm sitting here thinking about if somebody's listening to this and they're in a wheelchair with MS,
yeah,
looking at a drug that's costing $10,000 a month.
Right.
That's
More.
Really...
The average cost of an MS patient in the U.S. is $290,000 a year. Neil's treated MS in Panama for a decade and has complete resolution of a lot of patients. I mean, if you go to Patients for Ethical Use of Stem Cells, if you go to a lot of the support groups out there on the internet for MS and for stem cell use, those are all patients that Neil's treated, and patients that we've treated at the clinic.
Right.
What's so cool is when things like this open up and it allows people, like the article that I brought up where they were culturing these stem cells in CBD and in polyphenols, then the science can start expanding on itself. Then we can start looking at this. And
I get depressed a little bit because the science is so already out there. I mean, it's so hard to find a clinical study on the use of bone marrow aspirate concentrate in any part of the body that's not already written. The book, The O Shot by Dr. Runnels, was just using PRP. That was published a decade ago. Hair growth with PRP, decade ago. The vampire facelift with PRP, decade ago. Now with bone marrow aspirate concentrate and amnion, you can always, it ups the ante quite a bit. ED, we were talking a minute ago. Erectile dysfunction, in 2009, a paper was published in 12 out of 12 males, 70 years old, that didn't respond to orals. Status post-prostatectomy. Bone marrow, 60 cc's, condensed down to 6, 3 cc's in each side of the corpus cavernosum. And by the way, that doesn't hurt. It's not some giant painful shot. It's like a skin prick. Not to be, you can say a skin prick, but you can't. Never mind. So we're talking a fairly painless injection. 10 out of those 12 males at 2 years were still having spontaneous erections. Now, So that was the cure for ED in status post prostatectomy males without drugs in a one-time treatment with 2-year follow-up with 0 side effects. And that was 70-year-old bone marrow post-radiation.
Wow.
So not the best cells ever, right?
Yeah. But let's clarify. There's a
And
little
that was published in the Journal of Urology.
I could just see I got some pretty tough patients. I could just see some guy trying to pound his femur going, I need this bone marrow.
Yeah,
I'm like,
So that's
it works a little
important.
more complicated than that.
So you need to go to somebody you can trust too, because you had mentioned also in the past, and I've even heard from people who said, "Well, I've had stem cells injected," and then I would
Didn't
say,
work.
"Well, yeah, it didn't work,"
Didn't
and
work.
it turns out that they had used local.
Yeah.
Explain
well,
on
okay.
that.
So yeah, this is another pet peeve, right? Unfortunately, I guess I have a growing fortitude and growing fortress of pet peeves. And you can watch it all day. If you watch stem cell injection on the internet, go to YouTube. The toxic dose of local anesthetic, epinephrine, or corticosteroids, all corticosteroids, triamcinolone, dexamethasone, Kenalog, bupivacaine, Marcaine, lidocaine, epi, the amount that's safe on a stem cell injection is 0. So
what does it do to the stem cells?
it lyses them and destroys the cell wall. So that you destroy them on contact, right? So in culture, none of these cells make it through the first hour if you add a drop of lidocaine to your culture platter, right? So when you see someone get a stem cell injection, quote unquote, and they add lidocaine, local anesthetic, or any steroid in the knee, you killed everything. So you turned what could have been a stem cell injection into some growth factors. I mean, you don't unravel all the proteins with that injection. You destroy all the cell walls. So you're no longer getting a stem cell injection.
It's just growth factor with no differentiated cells, right? Okay.
Yeah. So it may make you a little bit better, but it's not going to grow tissue. You're not going to grow cartilage from that
Sure.
because there's no cells. You weren't given a stem cell injection. You were given a stem cell injection right up until you put local anesthetic or steroid around it, and it kills everything.
Do you see the future of this as being a mix between the amniotic and the patient's own bone marrow?
I think well, that's what's legal, right? So right now that's all we have, and that's what's legal in the States. And we would never culture bone marrow because you can grow tumors if you get about 5 cell passes with bone marrow aspirate concentrate. You with cellular expansion, you can get some mutagenic component of that that you don't get with postnatal tissue. By the way, as you culturally expand postnatal tissue, you don't have the mutagenic potential or meaning to form a tumor or cancer that you do with bone marrow aspirate concentrate. But no, I think that the future would be a graft created from the umbilical tube that also has the stromal tissue. There's a cell, stem cell now that when we were in medical school wasn't a stem cell. It was an undifferentiated mononuclear endothelial cell. It's in every capillary bed. It's actually the most numerous stem cell in the human body. It's in every capillary bed you have. And that cell is called a pericyte. And a pericyte wasn't a pericyte 5 years ago. A pericyte is a stem cell. And that's a cell that is the first cell to see a wound. It's the first cell to drive growth factors in. It's the first cell to cause the hemopoietic or the CD34 cell to come into the wound. The pericyte, if we could turn a graft from umbilical tissue that involved that cell, that we could culturally expand.
I'm sorry, if you can make a graft from umbilical tissue and that tissue?
Yeah. So the amnion's the lining of the umbilical cord. It's a covering. The stromal tissue, the umbilical cord has 3 vessels in it. What's being done right now in most places in the world is from Wharton's jelly. It's the jelly around those 3 vessels. That's where there's some stem cells. But they're not the best. So people talk about cord blood. There's no stem cells in cord blood. Cord blood is undifferentiated blood. It's good. There's no stem cells. The stem cells are in the stromal tissue, the perivascular tissue, the lining, the collagen fibers. That's where those stem cells are trapped.
So this is where a lot of confusion comes in. Because I even had a friend that actually I think he interviewed, and the question was brought up, and there's so much confusion with it that everybody thinks it's cord blood that's going on.
And it's not. Yeah, there's no cord blood. Look, I have cord blood stored from all 3 of my daughters. I have and let's tell you about my life when I said I was a mess. I have a 22-year-old, a 17-year-old, a 6-year-old. So I have all their cord blood. And in 2008, the U.S. government decided they own it. So I still pay the storage fees on it, but I'm not allowed access to it unless they are treated And if my kids have an FDA-approved diagnosis for the use of cultured and expanded cord blood, they'll give some of that to me and let me treat the kid. So if there's 3 different types of leukemia right now that are completely curable, if you have cord blood stored in your kid or first-degree sibling gets one of those types of leukemia, it's 100% curable from the cord blood you have stored. And that's all the FDA will allow you to treat. But if you have osteoarthritis, daddy gets osteoarthritis in his knee. If I could take some of the cord blood, culture the tissue, create the cells that are in it, and to make them where they would matter from the umbilical tissue, I could just use that and treat your knee. That'd be awesome. But it's illegal.
Wow. That is a lot.
And depressing.
Yeah, it is.
I mean, I'm literally thinking of people with heart failure, people, with, let me ask you.
The heart failure study, they actually took those cells and they were squirting them in the pericardium. This is a different study, but in mice, they were squirting in the pericardium and the mouse to cure heart failure, and it worked. But they couldn't, when they killed the mice, there was none of those cells within the heart. So how did it cure the heart failure?
Yeah.
So then they gave them intravascular, still cured the heart failure. But they couldn't get the cells in the heart. Then he injected them in the calf of the mice where they couldn't move and still cured the heart failure.
Quick question. Does it help the brain? Alzheimer's?
30 seconds.
Degeneration?
Sure. And I think there would be a really good way. The problem is getting those cells past the blood-brain barrier. And the only way to do that would be as a nasal spray of growth factors on the cribriform plate with you laying down to treat like a post-concussion syndrome. That may or may not have been done with significant success, but it's not going to be allowed in the U.S. for quite some time.
Wade, come back. Check out stem
Holy
cell
cow.
expert, Dr. WadeMcKenna.com.
A lot of material. Everyone needs to know this.